Welcome to the second session in the Data for Health, Data for COVID-19 series hosted by Bloomberg Philanthropies. My name is Carlos Roig and I'll be moderating these sessions. Last week, we were so pleased to have more than 260 participants registered from more than 50 countries. This week, there are 270 participants registered from 45 countries. This session is being brought to you by Bloomberg Philanthropies, an organization founded by Mike Bloomberg that uses data to ensure better, longer lives for the greatest number of people. As you know, the goal of the Data for Health initiative is to partner with countries to improve their public health data. The COVID-19 pandemic has reached nearly every country in the world, and during this crisis, high-quality data is more important than ever. This series aims to provide technical assistance to support your ongoing COVID-19 work. Before I hand this over to our presenters, I wanted to go over a few pieces of information to help you navigate the platform. An interactive poll will be shared during the webinar, and time is allotted for moderated discussion. This webinar will be conducted in English with simultaneous translation in French and Spanish. You can switch languages via the translation button. Finally, you will notice a chat button at the bottom of your screen if you're using a computer, and at the top of the screen if you're using a phone. Please direct your chat to everyone, which is the default setting. Please use this feature at any time to type questions you have about the presentation or anything related to the series. International Data for Health partners will answer as many of these questions as possible at the end. This session will largely be focused on the certification and coding of COVID-19 deaths, but first, Danny McGoldrick and Lynn Safraza from the Global Health Advocacy Incubator will provide an overview of issues related to CRVS legal frameworks during an emergency. Danny, over to you.
Thanks, Carlos, and hello, everyone. The Global Health Advocacy Incubator, next slide, please, partners with civil society organizations who advocate for public health policies around the world that reduce death and disease. And a key facet of our work is legal analysis to ensure that laws and policies reflect best public health practice. Next slide. On the Bloomberg Data for Health initiative, the incubator works with our global partners and local lawyers and stakeholders using a toolkit to conduct comprehensive legal reviews to help ensure that the country's legal framework facilitates best practice for CRVS. Very quickly, what we do with our working with local lawyers is to collect and analyze all the relevant laws and compare those to best practice for CRVS. We identify gaps in those laws and policies and recommend legislative and regulatory fixes, and then provide technical assistance in the drafting of laws and regulations to implement those recommendations. I'm going to turn it over to my colleague, Lynn Safraza, who will explain how a strong legal framework is essential for supporting civil registration, particularly during times of public health emergencies like today's pandemic. Lynn?
Thanks, Danny. Like Danny said, I'm going to speak about a strong legal framework and how it can support civil registration during public health emergencies. But first, I'd like to stress that civil registration is an essential service. Data collected during this time, particularly cause of death data, is essential for developing policy response both during and after the pandemic. But even where cause of death data is limited, death registration is essential because it provides information and insights on population health outcomes just by knowing about the fact of death. Birth registration is equally important because it provides the foundation for legal identity. So lack of access to birth registration at this time risks further marginalization of vulnerable populations and may restrict access to essential services in the future. Next slide, please. Laws can help enable or hinder registration during emergencies. A rapid review of laws can help identify obstacles and allow for modification. For example, it's good practice for civil registration laws to authorize registrars to manage personnel, set operating procedures, and waive fees. This allows the system to be responsive at all times, but is particularly important during times of emergency. Right now, registrars need these powers to modify procedures to protect the health of registration personnel and the public. For example, registrars should promote registration online, by email, or by phone to the fullest extent possible. Registrars may need to reduce staff to allow for physical distancing or extend business hours to minimize crowding. And registrars should waive fees for late registration for those who cannot register on time right now. But some countries have older laws that don't allow registrars to take these steps. For example, older laws require paper-based processes and in-person processes, such as signing in front of the registrar. Fees might be set in law, giving no authority to registrars to waive fees, and laws may not allow registrars to modify government business hours. All of this can impede registration at this time. Next slide, please. Other laws can impact the notification of deaths as well. For example, emergency public health laws that require rapid disposal of the deceased may impede identification and registration of the deceased. But at the same time, laws that connect the public health authorities to the civil registration system can help ensure that these deaths are registered. Similarly, laws that require funeral homes, cemeteries, or crematoria to report on disposal of bodies to the registration system can help ensure all these deaths are registered. So a rapid review of laws and taking action to allow temporary modification during the pandemic can help maintain the civil registration system at this time. Next slide, please. An after-action review after the pandemic has passed or the initial crisis has passed should include a review of laws. This will help identify whether laws enabled or impeded an effective response and can highlight ways to make changes to better respond to emergencies in the future. Next slide. So here are just a few resources for reviewing laws, including the Data for Health Toolkit, Legal Review Toolkit, as well as resources for maintaining civil registration during COVID-19. This has been a brief review of our work and its application to the current pandemic. We're considering adding a session to this series on ways civil registration systems are responding to the pandemic. We'd like to get your opinion on this, so please respond to the poll on your screen. This poll will be up for 15 seconds. Next, we'll hear from Sam Knotson from the National Center for Health Statistics at CDC.
Thank you, Len. Next slide, please. The emergence of a new disease frequently leads to uncertainty or confusion about how to report the disease. Over time, with some consensus on the characteristics of the disease and so on, the WHO will issue guidance on proper reporting, and countries will then adapt that for local use. Last week's webinar focused on the reporting of deaths in order to make the case for rapid mortality surveillance. However, as stated here, the cause of death information from death certificates is an essential element of mortality surveillance. So for this reason, ensuring proper guidance of physicians and medical coders is crucial. Next slide, please. Just a few brief comments on the underreporting of COVID-19 before we move on to our two main panelists. In addition to the undercounting at the very onset of this epidemic, there are certainly other issues that can be at play. A couple of those concern the location of the death. For example, deaths at home or deaths in nursing homes. In the nursing homes, frequently, especially early in an outbreak, a respiratory disease like COVID-19 might well be reported as pneumonia. This appears to have been the case in northern Italy. And the authorities in France have determined that their rapid mortality surveillance system was missing a number of COVID-19 deaths because it did not include nursing homes. And I just want to stress that's been corrected since then. In addition, there are different reporting standards. Physicians are receiving standard guidance on how to report COVID-19, but are also told to use their best medical judgment. So necessarily, this will vary from one physician to another. In addition, medical examiners typically require a positive test for an infectious disease such as COVID-19 in order to mention that on the death certificate, while other physicians may be more willing to report conditions such as suspected COVID-19, probable COVID-19, and the like in the absence of a positive test, but in the presence of the standard symptoms for COVID-19. So for this reason, it would be best to ensure that all physicians receive guidance that conforms to international standards. So now I'd like to ask Dr. Robert Jacob, the lead for the WHO unit on classifications and terminologies, which includes the International Classification of Disease, to discuss WHO standards for reporting COVID-19.
Thank you. Please continue to the next slide. Thank you. So the most important thing is that we all count the same thing. And although we all thinking we count the same thing, we need to have a definition to say, what do we count in the context of COVID? And what we count are deaths due to COVID. So where the death is due to a disease, to an illness that is probable or confirmed COVID-19 case, and where there is clearly no alternative case or cause of death that cannot be related to the COVID, for example, like an accident, a trauma or something. Next. Next slide. So the clinical definition for COVID, we have been asked several times. So please don't forget in this whole context that we are all still in the learning phase. A lot of research is going on. We know typical signs and symptoms and findings. So what you see here is being collated from the WHO webpage that mentions COVID and gives COVID guidance, just to show you what kind of range of symptoms and signs we have, many of which are not so specific. And for this reason, the diagnosis needs to be really done by a physician to assess whether this is a COVID case or not. Next slide. There have been also many questions on testing, diagnosis, and tests to be used in that context to be sure whether there is a COVID case or not. Most recently, this week actually, a new document that provides guidance on testing and diagnostics has been published by WHO. You will find all this information under the links here, and that's the most up-to-date knowledge. Next slide. So, but let's look first on what we do for standardizing the reporting of cause of death. One thing is the definition of what is a death due to COVID, but the other thing is also to report these cases in a standard way. And so there is a WHO definition that says that the underlying cause of death is the disease that initiated a sequence of events that led directly to death. And so in the case of COVID, for example, COVID is causing a pneumonia. The pneumonia is causing a respiratory distress syndrome that in the end gets to a situation where the person dies. Next slide. So in general, the medical certificate of cause of death should be filled in by a physician, but best not by any physician, but by a well-trained physician that really knows how to assess the sequence of events and diagnoses that led to death, that can base this diagnosis on a careful examination of the dead body, and that also uses all the available information. So there may be the medical history available, records, laboratory tests, autopsy reports, and all other information even provided by the family, drugs around. So really to get a full picture on what have been the circumstances so that this sequence can be assessed. Next slide. And this is how the International Medical Certificate of Cause of Death looks like. So it has different sections, as we can see, that serve to fill in the relevant medical detail. Optically, there may be slight variance depending on the individual country, but the content is usually the same. Next slide. So the certificate consists of two big parts called Frame A and Frame B. Frame A is subdivided in a part 1 and a part 2. Part 1, where you put the sequence of events that led to death. In part 2, you can put other conditions that may have contributed to the death, but that do not fall into the sequence. And in Frame B, we put additional information that is frequently forgotten. Next slide. In part 1 is this place where we call the sequence and write it down in a correct way. On the topmost line, we put the immediate cause. So in the case of the COVID, eventually the acute respiratory distress syndrome. Then we would have on the line below, this is caused or due to a pneumonia, intermediate cause. And then the bottom line would then be underlying cause of death. And this is how you fill in a sequence, but this is true also for other diseases. You always have a kind of sequence of events that leads to death. Of course, please remember when you report for other reasons an injury that led to death, that you please also provide information about the type of accident or assault or other events from outside that created the death, because this is what can be prevented eventually in public health. And don't waste space with trivialities like cardiac arrest and respiratory arrests. They always occur in the context of death. Next slide. Next slide. This is how this part looks more in detail, and you see there are instructions given on the side on the sequence so that we can be sure that top down to fill it from the closest event to the most distant event, and that you can also have space for recording these other significant conditions that may have contributed. Next slide. And now here we have the frame B that essentially shows this additional information. You find here some questions in relation to surgery, to the manner of death, the place where the external cause occurred, perinatal deaths and maternal deaths. This is important information. In the past, this was not asked separately, but this is frequently forgotten when filling in the frame A. So having this asked for explicitly, it allows for doing correct statistics and complete information that informs your policies and your prevention programs. Next slide. And last not least, don't forget to fill in the time interval from onset of the disease to death. It's important information. It allows to assess the plausibility of the sequence. It also reminds the certifier about what happened there. And please don't confuse this with the time of diagnosis of the condition was made. It's the time of interval between onset of the condition and death. Next slide. So now what does this all mean in the context of COVID? Next slide. So one thing is important, COVID should be recorded on the certificate for all deaths where the disease caused or is assumed to have caused or contributed death. Why are we highlighting this? Because people use so many variant terms that it's sometimes challenging for the people that assess the content of a certificate to find out what did they mean with this. And so please, if you think that probably or most likely or for sure the death involved COVID-19, please put COVID-19 on the certificate. Next slide. So fill in the causal sequence on the certificate like you would do for any other death. Don't do anything for the COVID differently from normal. So if the sequence has been the pneumonia, the respiratory distress, and both caused by COVID, fill in the sequence as you usually would do. And if you have some uncertainties about additional information, please place them on the certificate so that those who analyze the certificates can have all the information they need to extract the correct single underlying cause of death following WHO standards. Next slide. So, of course, we have heard that people can die of COVID, also having other conditions at the same time. Some of these conditions may even increase the risk of falling seriously ill. Well, place them on the certificate, place them in part 2, because they may have contributed to the seriousity of the course, but they probably have not been causing the COVID infection. Next slide. In order to be able to collate data internationally, WHO has released emergency codes as early as in January this year to be able to document cases and record cases in the statistics system that are due to COVID-19. And we added a second code so that we can distinguish eventually between cases where the virus has been identified and cases where the virus has not identified. And both codes are valid codes for mortality coding. If you want to know more about these codes and their handling, we put a link here that would help you to get to the relevant guidance. Next slide. Similarly, for ICD-11, we have 2 codes and the guidance in the same document. You may wonder why I put ICD-11. Well, there are countries that are already using ICD-11 in mortality. Next slide. And now from these certificates, the way they are filled out, we need to distill the single underlying cause of death. If the person that has filled in the certificate, the physician, has followed the instructions and has put a plain sequence, I think the work is rather easy, but sometimes people don't know the rules, don't follow the rules, or are uncertain about the detail, and we will see more later. And then there are a set of rules that make sure everybody selects this content, the underlying cause of death, in the same way from the death certificate. We have this in the volume 2, the instruction manual of ICD-10. There's a whole set of rules. And similarly, we have in the reference guide of ICD-11, this kind of codes and rules. Next slide. We also have WHO training materials on how to fill in a death certificate in an interactive self-learning tool that is looking at physicians and at coders. And you see here the link how to find this easily. Next slide. We also have additional information that is part of the volume 2 of the instruction manual of the ICD-10. Everybody who has a version of ICD-10 2016 or later that has been translated into a national language will find this flyer, this information at the end of the book in the annexes, and the English version you can find online under this link. Next slide. And to finish with, here is also a cause of death flyer. Similar flyers are used in many countries. This is really to easily address the physician telling, number one, why this information is collected and what is done with it, and to reduce the worries that this is to monitor the quality of the physician's work. It is not, it's to inform public health. And how to fill in this form, different instructions step by step to avoid things that create trouble to the people that use the certificates, in particular to write legibly, please, and don't use abbreviations. And finally, it even gives a list of instances where clinicians don't think about the detail necessary for public health, but they would have it, and giving a hint on how to solve this. With this, I conclude this part explaining what the WHO standards are, and would hand over to Leanne Flagg of the National Center for Health Statistics in the CDC. Thank you.
Thanks, Robert. So I'm going to touch on some of the roles and responsibilities in death certification, and also briefly go over some of just the general guidelines, the guidance for COVID-19, just because it's so important. And then I'll get into some common problems that we see in the US and some example scenarios. And then I'll show just briefly an example of kind of what we've done with some of the data. So there are, of course, a lot of people involved in death registration. Typically, funeral directors will report the demographic information on the death certificate. Things like age, sex, place of death, race, and ethnicity. And then physicians and medical examiners or coroners will be providing the medical information. And physicians should be certifying deaths due to natural causes, and then medical examiners and coroners should be certifying deaths due to injuries or poisonings, suspicious deaths, and any sudden or unattended death. In the case of COVID-19, they will predominantly be natural. Next slide. So deaths due to injuries, poisonings, and complications thereof should be referred to the medical examiner or coroner. In the US, we have 57 vital registration jurisdictions, and each one is a little bit different. And some of them, the laws or regulations require referral for deaths due to a public health threat, such as a pandemic like COVID-19. And again, they vary a bit, so we just encourage our certifiers to be aware of those laws and regulations. Next slide. So a lot of deaths can appear to be natural, but could be a complication of an injury or poisoning, possibly occurring long ago. So this is just a list of examples. It's not necessarily exhaustive, but they might appear to be natural, but if the certifier were to look further back into the medical history, it might be a complication of an injury or poisoning, so would possibly indicate referral to the medical examiner or coroner. If unsure, we encourage our certifiers to just consult the medical examiner or coroner in the jurisdiction in which the death occurred. Next slide. So again, we want our certifiers to use any information that's available to them in the determination of the cause of death. So any medical history or records, laboratory tests, an autopsy report if it's available, or any other relevant source of information. Like a lot of other medical diagnoses, a cause of death statement is an informed medical opinion, but it should be based on sound judgment drawn from their clinical training and experience. And so all cause of death statements are a medical opinion. We don't merely ask what conditions the decedent had at the time of death. We want to know in the certifier's judgment which conditions they believe actually caused the death. So again, all cause of death statements are opinion. There's no such thing as a measure, an objective measure of cause of death. So we frequently encourage our certifiers to use their best medical judgment. Next slide. So like Robert said, if COVID-19 is determined to be a cause of death, it should be reported on the death certificate, likely as an underlying cause of death. And so it would be on the lowest line used in part 1, and then any complications it leads to in a logical order on the lines above it. If possible, we really want people to do testing, and we're pointing them to the CDC guidelines and recommendations for a person under investigation, as well as those for reporting and testing and specimen collection, including for postmortem testing. So if a definite diagnosis cannot be made, but the certifier determines that it's suspected or likely, meaning they found the circumstances compelling within a reasonable degree of certainty, they can report a cause on the death certificate as probable or presumed. And again, they need to just use their best clinical judgment in determining whether the decedent had COVID-19 and it was a likely cause of death. One thing I've been pointing out is we've seen some reports of possible COVID-19 exposure or COVID-19 exposure, and we don't really want people to do that. So we want them to actually make a determination if the decedent had COVID-19 and it was a cause. Of course, a lot of people are going to be exposed to this virus, but that doesn't mean they're going to develop the disease or die from it. So we really want them to think through and determine if they think COVID-19 was likely a cause of death. Generally, we ask the certifiers to avoid abbreviations and acronyms, but since COVID-19 is unambiguous, we are saying it's okay to report it on a death certificate. And then, like Robert said, pre-existing conditions that may increase one's likelihood of developing the disease or impact their survival from it, things like COPD, asthma, hypertension, diabetes, so forth, those should go in part 2 if they're contributing to the death. One thing I like to point out is that we don't necessarily want a laundry list of every condition the decedent had at the time of death. We really just want the ones that actually contributed to death. Next slide. So I'm going to talk about some of the common problems we see in the US in cause of death statements using some COVID-related examples. So the first one is intermediate causes or immediate causes reported without an underlying cause. And so this is problematic because in a sense, the underlying cause of death is missing. Or in other words, they're reporting the intermediate cause as the underlying cause of death, but it really leaves us wondering what led to that person's death. So it really should not be something that has multiple possible underlying etiologies. So one example related to COVID-19 would be pneumonia. So it should be reported on a death certificate, that is good, but we still need them to provide an underlying cause of death, as there are a lot of different things that can cause pneumonia. Of course, various infectious agents can cause it. It can be caused by inhaling a liquid. So we just really don't know what initiated that train of events that led to that person's death. And then on the right here, just showing an example in the case of COVID-19, a better statement would be pneumonia due to COVID-19, and that brings us back to an underlying cause. Now, we understand that sometimes certifiers may not know what led to that condition, and so what we tell them is that they can report, say, the pneumonia and then etiology unknown. Next slide. Another common problem is specificity. So of course we want conditions that are reported on the death certificate to be specific enough to be useful for public health and research purposes. So just an example, say if someone reported viral infection, it's not very specific. A more specific cause of death statement would be sepsis due to COVID-19 if that's what the case was. Another thing we've been seeing a little bit is COVID or coronavirus. If they're talking about the 2019 strain that's not specific enough, we really would want them to specify COVID-19 if that's what it was, just so we would be able to distinguish, this COVID-19 strain from other coronaviruses. Next slide. And then the last most common problem we have is with sequencing. So we do get a logical sequence and sequences. An example of this would be COVID-19 due to COPD, which is not logical because COPD doesn't cause COVID-19. The virus SARS-CoV-2 does. So in this instance, really the COPD would be more appropriately reported in part 2. And then on the right, I have a logical sequence. So ARDS due to pneumonia due to COVID-19, and that makes sense. Now, there can be reasonable differences in medical opinion concerning sequence for a particular death, but regardless, all reported cause of death sequences should be logical in terms of time and etiology. Next slide. Next slide. Okay, so now I'm going to just show a few case histories with example certifications in the case of COVID-19. Next slide. The first one is a 77-year-old male with hypertension and COPD. He presented to the ED with 4 days of fever, cough, and increasing shortness of breath. He had been recently exposed to a neighbor with flu-like symptoms, and his wheezing was not improving with his usual bronchodilator therapy. He was found to be febrile, hypoxic, and in moderate respiratory distress, and his chest x-ray indicated hyperinflation. His ABG was consistent with severe respiratory acidosis, and testing of respiratory specimens indicated COVID-19. He was admitted to the ICU, and despite treatment, his respiratory acidosis got worse, and he suffered a cardiac arrest on day 3. Next slide. So here, the immediate cause of death was acute respiratory acidosis. So it was reported on line A. as a consequence of COVID-19. So that was reported on line B, the lowest line used in part 1. And then the COPD and hypertension weren't part of that causal sequence in part 1, but they contributed to the death, so they were reported in part 2. Next slide. Here we have a 34-year-old female with no significant medical history. She presented to her primary care physician with 6 days of fever, cough, and myalgias. She was found to be febrile, hypotensive, and hypoxic, and she was admitted. A CT scan of the chest revealed diffuse ground glass opacification indicative of viral pneumonia. PCR testing confirmed COVID-19. Her condition got worse over the next 2 days and she developed ARDS. She was transferred to the ICU and started on positive pressure ventilation, but expired on hospital day 4. Next slide. And so the immediate cause of death was the ARDS, so it was reported on line A, which was a consequence of pneumonia, reported on line B, which was a consequence of COVID-19, reported on line C as the underlying cause of death. And so this is a good cause of death statement. It is a logical sequence, and it goes all the way back to a specific underlying cause. Next slide. In our last example, we have an 86-year-old female with unconfirmed COVID-19. She passed away at home. Her husband had reported she was non-ambulatory after an ischemic stroke 3 years ago. 5 days prior to her death, she developed a high fever and severe cough after exposure to an ill family member who had been diagnosed with COVID-19. She refused to go to the hospital even when her breathing became more labored and her temperature escalated, and she was unresponsive that morning. When EMS arrived, she was pulseless and apneic, and her husband said that they had advanced directives and she was not to be resuscitated. EMS consulted medical command, pronounced her dead, and then notified the coroner. Next slide. So here's an example of how it can be okay to report a condition if the certifier is not certain, but they make the determination that it is a probable or likely cause of death using their best clinical judgment. So although no testing had been conducted, the coroner determined that the likely underlying cause of death was COVID-19, given the decedent's symptoms and exposure to a person known to have COVID-19. So therefore, they reported COVID-19 on the lowest line used in part 1 as the underlying cause of death. The ischemic stroke was not part of that sequence in part 1, but they determined that was contributing to the death, so it was appropriately reported in part 2. Next slide. So some key takeaways that we stress with our certifiers, and again, using all pertinent information that's available to them and their best clinical judgment, we ask them to report an underlying cause of death that is specific. So in this case, it's COVID-19, and a logical sequence in part 1, meaning comorbidities in part 2. So again, we want them to provide an underlying cause of death that is specific and a logical sequence. And that way, they will be likely providing the high quality cause of death information that we need to understand and fight this pandemic. Next slide. And then this is just a screenshot of the vital statistics reporting guidance that we released. It has more details and information, and if people want more of that information, they can take a look at it. The URL is there. Next slide. And then I'm just going to show one very brief example of some of the data, or what we do with the data from death certificates in surveillance. Next slide. So this is just a screenshot of our National Vital Statistics System COVID page. This is where we're publishing our guidance and any alerts, and also where the surveillance or the provisional counts can be found. And the URL there is listed there if people want to take a look for more information. Next slide. And then this is just one table from the provisional counts. And this is deaths involving COVID-19 nationally by week. This is just data as of last Friday. And so this only includes deaths that we had received and coded by that date. And so the data are actually incomplete. Typically, these numbers, our death certificate numbers, are 1 or 2 weeks behind other data sources. We do update them daily, Monday through Friday. And we're showing national death counts here by week. We also have age, sex, and place of death, as well as race and ethnicity. And we're also showing things by state. Next slide. And then lastly, this is just some other CDC resources that we've been pointing our certifiers to. One that I will just highlight briefly is a cause of death mobile app that we released. And it's a free app that certifiers can download either to a smartphone or a tablet, whether it's Apple or Android. And it's just a quick reference guide that they can look at the point of certification and get just some quick guidance to help them when they may be certifying a cause of death. And we did link to the COVID-19 guidance there, so they'll be able to access it that way. And with that, I will turn it back over to Sam for some final comments.
Thank you, Leanne. Could we go to the next slide, please? First, I'm going to talk briefly about the IRIS automated coding system, and then we'll move on to sort of final wrap-up comments. First of all, for those of you who don't know, IRIS is a software system that automatically codes causes of death and is considered the global standard for automated coding. Within the Data for Health initiative, that involves, ultimately will involve 25 countries. There are several countries already using automated coding, already using IRIS, and certainly more will follow. There are a number of reasons for opting for automated over manual coding, but one that is particularly useful for diseases such as COVID-19 is that the automated coding systems really greatly facilitate extraction of additional information beyond the underlying cause of death. And in the case of COVID-19, that would include, for example, any mention of COVID-19 elsewhere on the death certificate when it was not chosen as the underlying cause. Another would be any mention of pre-existing conditions. Both of these would be important ultimately in understanding the final impact of COVID-19. In addition to that, I should note that IRIS has updated its software to include the codes for COVID-19 and updated other parts of the system involved in selecting the underlying cause. And they did that very quickly following release of the codes by WHO. Because I work somewhat with the IRIS group, I've noticed that there are a number of countries that apparently are using IRIS but do not participate in IRIS activities, such as the IRIS users group. Some of those may be simply countries testing the system to decide whether they would like to fully adopt it or not. And others may be using it in a simplified approach to coding called code-only mode. But regardless, they may not be aware of the fact that the software has been updated. And so for those countries, they should go to the IRIS Institute website, to the most recent edition of the IRIS newsletter, where they will find information on how to download the updated software for the system. Next slide, please. So finally, just a few comments in closing. The first is that inevitably there will be confusion associated with epidemics. But what this means is that countries will need to correct their data periodically. The second, The final understanding of the overall impact of COVID-19 will come later, perhaps much later, once additional data are assembled and a better understanding of the disease is established. And finally, the international standards for the coding of cause of death is useful for international comparability, but in this case, it's especially useful in assessing the impact of COVID-19. So I will end my comments there, and we will move on to the question and answer session. Thank you very much. Let's see if I can find some.
Hi, I'll jump in here as it seems we've lost Sam and begin to pose some of the questions until he returns. We do have a question about in the US reporting of COVID deaths. Does it include probable COVID deaths or just the confirmed deaths? And maybe we can start there and then we'll sort of move to other questions that come to me.
This is Leanne, I'll jump in. So yes, we do get reports of probable COVID-19 and they are coded to the U7.1 code. And this is a practice that still actually applies to all conditions. So any condition that's reported as probable, we will code it to the corresponding code. So yes, we do count those.
Thank you for that, Leanne. Next, we will go to a question from Australia. The question is, we know that COVID-19 deaths are being underdiagnosed even in developed countries. What can we do to help the doctors certify these deaths better? Robert, would you like to take that question?
Sure. So as I said at the beginning of my presentation, the clinical symptoms are not always 150% conclusive. We will have the tests, but the problem is not in the certification. I think people can be trained in certification using the different guides that exist. The problem relies in being able to diagnose the disease, and there we will learn more as we do. Most importantly, all deaths should be counted, all deaths should be reported on the standard certificates so that later in reviews and analysis we can learn if there have been other conditions reported that may or may not have been related to the COVID. Thank you.
Thank you, Robert. Now it looks like we have a question for the legal review team. Who conducts the rapid legal review? Lynn, would you like to take that one?
Sure, yes. Lawyers within the civil registration agency or within the ministry under which the civil registration agency sits would be best placed to do a rapid legal review because they would already be familiar with the laws applying to civil registration. So they should be the ones who do it. Just want to remind people that we might have a session on this. So if you're interested in this, leave comments in the survey at the end of the webinar.
Thank you, Lynn. Next, we have a question from Kenya. Is there a tool for coding and indexing of COVID-19? Saman, would you be willing to take this one on?
Yes, I'm happy. The question is about tools for coding and indexing of COVID-19. Tools are already available for coding and they have been updated to include codes for COVID-19. As you all know, in ICD-10, there are emergency ICD codes U07.1 and U07.2 for laboratory confirmed and clinical, epidemiological, or probable diagnosis of COVID-19. And then in ICD-11, the codes RA01.0 and RA01.1 are available for laboratory confirmed and clinical, epidemiological, or probable diagnosis of COVID-19. Guidelines about how to code deaths due to COVID-19 are already available from WHO. With reference to automated coding, IRIS version 5 is updated to code COVID-19 deaths. Decision tables embedded in news are updated to include the new ICD-10 COVID-19 codes. IRIS version 5 users can download and update their decision tables So decision tables updates are available in the IRIS website. And decision table updates are also available in a Microsoft Excel format, and they can be downloaded from IRIS website. For table D updates for the application of rules SP3 and SP4, and table E updates for SP6, M1 and M2 are available in Excel format. Coders who manually use decision tables to understand causal relationships and apply mortality coding rules are able to use these updated Excel tables. University of Melbourne, under the Bloomberg Data for Health initiative, is also developing a detailed coding guide with examples to help both manual and IRIS automated coders.
Thank you, Saman. Next, we have a question from, let's see, from Kenya on, could it be wise to collect data on respiratory infection to check over-reporting of COVID-19? Robert, would you like to answer that one?
Sure. Well, ideally, you would collect all causes of death to have a complete picture, because so far we know that COVID leads to a pneumonia that then may be aggravated to lead you to death. And we'll learn in the future if there are other conditions that could be a result of the COVID. So ideally, you collect a full certificate. And for the pneumonias, it depends on what is reported and how it is reported. Eventually, it can be an underreporting or an overreporting. We will know this only after careful assessment of the cases. So best you collect all cases, and whether then there is under and overreporting, the overall mortality rate will tell. Back to you.
Thank you very much, Robert. Let's see now. Here's another question from South Africa. How long does it take to assess whether the underlying cause is indeed COVID-19? Maybe Robert, would you like to do that one again?
Well, that's a good question. How long does it take to assess? The core question from my side certainly would be, what do you mean after death or before death or in the course of the disease? I think the clinicians will know the clinical course of the individual case. Ideally there's a laboratory testing, and so you will know what this is. I've seen also here in the chat some questions asking for, we don't have the lab test yet, but we suspect strongly this is COVID-19. For other deaths, sometimes you have the same thing, that some exams and other things are done after the first round of registration. Eventually, you need to update your data with the information that comes late. Back to you.
Thank you, Robert. Now, I have a question. I believe, Philip Settle, I think you could take care of this one. The question is, can cause of death be used in conjunction with the rapid mortality surveillance system described in last week's webinar?
Thanks, Sam. As we described, there are three ways in which cause of death can be introduced into the rapid mortality system. But at the outset, I want to stress a couple of things. One is that rapid mortality and reporting on the fact of death by age and sex shouldn't slow down or detract from the routine processes of civil registration or the certification of causes of death that goes on in health facilities according to the guidelines that we heard about today. But briefly, we can look at manner of death and the potential use of surveillance definitions of the suspected COVID-19, which we realize will lead to an overestimate at the population level. We can use the certification practices that were outlined today. And then there's the potential use of verbal autopsy, which is the subject of an upcoming webinar. So in those three ways, there can be a relationship between total mortality surveillance in the rapid way in which we described it last week and the causes of death that are occurring in the pandemic. Thanks, Sam.
Thank you. Thanks, Philip. Here's another question for the legal team. Can you register civil events mainly deaths and births online instead of manually?
Well, that's going to depend on, one, whether you have the technical capacity to register online, but also whether your laws allow it. So as I was saying, if your laws require in-person processes, that's exactly the type of thing that you'd want to assess with a rapid legal review and allow for temporary modification. And I say temporary modification because any modifications made at this time should have a sunset clause after the pandemic, and then do a review and modify your laws after the pandemic in a way that's systematic and complete.
Thank you, Lynn. And I guess that would apply in general in emergency situations?
Yes, that's correct. That's correct. Any modification should be temporary, and then you should be reviewing at the end for overall comprehensive updates.
Okay, here's another question from the Philippines. And Robert, I think probably this one would best go to you. The question is a probable COVID-19 diagnosis a garbage code?
Definitely it is not, because somebody has said it is probable, and so it should be coded to the U01.2 code as a probable cause of death.
Thank you. Leanne, here's another one for you, I think. How do we ensure everyone complies with the standards? For instance, doctors are told to write COVID-19 as the cause of death, as opposed to medics who are being told to use pneumonia.
That's interesting. I'm not sure where that guidance is coming from. From us at NCHS, we're encouraging them to report COVID-19 if that's what it is. And then it is appropriate still to report the pneumonia, but that's an obvious consequence of the COVID-19. So really the cause of death statement should be pneumonia due to COVID-19. We're not necessarily advocating for them to report one or over the other. Really, ideally, both should be reported. Back to you.
Thank you, Leanne. Let's see now, we're getting close to time. So I have what I think will be the final question. This should go to Philip. Is there a recommended way to include COVID in the WHO VA tool?
Not yet, but we're busily working on it. As part of the verbal autopsy reference group that already has convened to discuss what might be done in this regard, there should be new information coming, and certainly by the time the webinar rolls around, we'll have a more precise answer to that question. So watch this space. Thank you very much.
Thank you, Philip. And I believe we're at time, so this concludes this webinar on the certification and coding of COVID-19. Thanks to everyone for joining, and back to Carlos.
Thank you, Sam, and thank you to our presenters, and thank you all for joining us. Our next session will be at this same time, Wednesday, May 6th at 8 a.m. Eastern Standard Time. We will cover verbal autopsy in the context of COVID-19. Please note that this session has been recorded, and we will circulate this recording as well as the presented slides to the group. When the session ends, you will be prompted to take a short survey, which should only take a few minutes to complete. We will try to respond to most unanswered questions in a subsequent email or session. Thank you again for your participation. We look forward to hosting many of you during the session next week. Please look out for an email with more information on that. Thank you.